computer and begin. Welcome, everyone, to this month's Spirituality and Health Research Seminar at Duke University. We are so honored to be able to hear Dr. Alexander Almeida talk about the World Psychiatric Association position statement on religion, spirituality, and the implications for clinical practice. So Alexander is an associate professor of psychiatry and director of the Research Center on Spirituality and Health at the School of Medicine, Federal University of Juiz de Fora in Brazil. Now, I'm sure I'm not saying these words correctly.
No, it's good. It's good.
We're giving it a try here. Yeah. He is chair of the section on spirituality of the Latin American Psychiatric Association. He's also former chair of the sections on spirituality of the World Psychiatric Association, and as part of the Brazilian Psychiatric Association. And he actually developed the proposal and the approval of the WPA position statement on spirituality and religion in psychiatry. So there is no better person to talk about this topic than Alexander. He's also author of more than 160 scientific papers and book chapters, and he has 2 edited books, one by Oxford University Press that has just recently come out, titled Spirituality and Mental Health Across Cultures. So that's going to be a volume that many of you will be should be very interested in. And also Exploring Frontiers of the Mind-Body Relationship by Springer, published in 2012. He also coordinates a TV Nupus show, which is a bilingual YouTube channel on science, health, and spirituality with more than 300 videos with more than 60 experts in the field. So, but his most important accolade is that he has been my colleague for the last 16 years. And it is really a special honor of mine to be able to introduce him for this lecture. So Alexander, take it away.
Dr. Carnegie, thank you very much. Good afternoon. Good afternoon, everyone who is here with watching us. It's a great pleasure, a great honor being here. As I was talking to Dr. Carnegie, 16 years ago, I was there as a postdoctoral fellow, and I learned a lot. And definitely, Dr. Carnegie has had a major impact in my career, in the way I do research and how I learned to work in this field. So thank you very much, and I hope to be at the level that that deserves the research that you have done and all that you have done to the field. Thank you very much.
Thank you, Alexander.
So my presentation, I will try to talk in about 45 minutes, so we could have about 10 minutes to discussion. And I will present the WPA position statement on religion and spirituality, research, and clinical implications. The position statement was published at the World Psychiatry. It was approved and published in 2016. It was put at the World Psychiatry. It has been translated to 7 different languages, okay, to Portuguese, Spanish, French, Dutch, Arabic, and Chinese. All these translations are available at the website of the WPA section on religion, spirituality, and psychiatry. Okay, so we will present here some aspects of the position statement, discuss how it has implications in our clinical practice and research, and also I will try to illustrate several of these points with the research with some studies that we have conducted here in our research group here. So the first point, so this is the first part of the position statement. It states that we need to promote mental health that should take in consideration the scientific evidence, but also it must be compassionate and culturally sensitive. And more than 3,000 studies have been published. And Dr. Koenig, in his 2 handbooks, have reviewed more than 3,000 studies. And definitely the 3rd edition will have much more studies. So there is no doubt anymore that there is some correlation between spirituality and health, and how important is spirituality to humanity. Because religious spirituality has implications for the prevalence of mental disorders, especially, for example, depression, substance use disorders. For the diagnosis, for example, differential diagnosis between spiritual experience and mental disorders. For the treatment, the spiritually integrated treatments, or sometimes religious reasons to refuse treatment. It has impact on outcomes, for example, in suicidal deaths, and also in prevention in quality of life. But also, as we know, spirituality can also cause harm. So we need to take this in consideration. Just to give an example about the importance of spirituality to the world population, this is data from Pew Research Center, showing that only 16% of the world population declares having no religious affiliation. So 84% of the population, of the world population, declares having some kind of religious affiliation, but definitely many, perhaps most of these 16 unaffiliated people, perhaps most of them, and probably they have some sort of spirituality, some spiritual practices, spiritual beliefs, and so on and so forth. But it's also very important to know that it's not that it is this way now, but also the predictions are that in the future, in the next decades, the world population will become even more religious. So these are the predictions from the Pew Research Center that to 2060. So the percentage of unaffiliated people is predicted to decrease from 16 to 13%. Actually, it is already decreasing in the global population. We need to be very careful to not extrapolate what is happening in some parts of the world to the whole world's population. So it's very important, and probably it will remain even more important, the religious affiliation of people. But even among the non-affiliated, most of them have some sort of spiritual beliefs or practices. Just to give an example, the belief in life after death, for example. This is a belief very prevalent around the globe. Most of the world population believe in life after death. And not only this belief is very prevalent, but also contrary to what many people have thought, quite often there is no correlation between the belief in afterlife and educational level, for example. In the United States, several studies have found no correlation between believing afterlife and educational level. But in other countries, for example, in Brazil, this is one study that we performed in Brazil, but also studies in France and Russia found a direct correlation. The higher the educational level, the higher the frequency in afterlife beliefs. So sometimes people think that more educated people would necessarily fuse the idea of life after death, but results and findings from different countries have found in the opposite way. Okay, so this is just some idea about the importance, the relevance of the belief and the implications for the clinical practice. As we know, there are thousands of empirical studies on spirituality, religion, and health. This is the second edition of the handbook of Harold Koenig. And this is the book that we have just published, edited, also providing an overview of the evidence for the impact of spirituality and health, but also about the clinical implications. How can we translate this knowledge to clinical practice? And in this book, reflecting the widespread interest in the subject, we have 38 different authors from 11 different countries, from all continents, showing how it has raised attention and research around the globe. As we know, higher levels of religion and spirituality are usually associated with lower general mortality, lower depression, suicidal behavior, substance use abuse, and higher levels of quality of life, well-being, and human flourish. However, there are also the negative impacts, like negative religious coping, extreme religiosity, and conflicts about treatment. It can impact negatively the outcomes of mental health, mental disorders, or other problems. It's very important that the position statement takes in consideration that in valuing the spirituality, of course, we do not need to deny the biopsychosocial aspects of health of human beings. We are claiming for a biopsychosocial spiritual approach to integrate spirituality in the others, because we know that health is a delicate and dynamic balance between pathogenic and salutogenic factors. So the idea in terms of prevention and treatment is decreasing the pathogenic factors and increasing the biopsychosocial spiritual salutogenic factors. So we always have to keep this in mind to advance and promote a full recovery and a flourishing life. Just to give an example, this is a study with bipolar patients, 160 bipolar outpatients here in Brazil. We found, for example, that patients who had higher levels of positive religious coping had 4 times less depression than those who had lower levels of positive religious coping. However, we found also that 23% of patients report some interference in the treatment by the religious leader. So this is definitely a matter of concern. And we also perform a 2-year follow-up prospective study with these patients. It's very interesting because nowadays in psychiatry, we are focused not only in symptoms remission. Of course, this is important, symptoms remission, but we are focused more and more on full recovery of the quality of life, of the functionality, the well-being as a whole. And in this 2-year follow-up, most of patients become euthymic. They were not depressed, not many. However, despite most of these patients were euthymic, they had higher levels of variation in terms of quality of life, in terms in full recovery, in several dimensions of quality of life, in physical, mental, social, and environmental. And what we found, what's most interesting, was that despite they are euthymic, we found that people who had positive religious coping in the beginning of the follow-up, they had on average about 10 points more in quality of life 2 years later. Quality of life in all dimensions, physical, mental, social, and environmental. However, the negative religious coping, although less frequent than the positive religious coping, was related to less 28 to 20 points in quality of life. So despite negative religious coping was less prevalent, the impact, the effect size was higher than the positive religious coping. So we need to be very careful in taking into consideration the negative religious coping, the religious struggles, as we know. Another example about the impact of spirituality is one of the most well-documented relationships is regarding substance use and abuse. This is a large national sample of Brazilian university students. We had 12,000 students, university students in Brazil, and we found that those who do not have religious involvement had on average twice the chance of having used legal and illegal drugs in the last month. So this is another example of this impact. And there is also another important aspect in terms of well-being and happiness. For example, here we investigated 160 chronic renal failure patients with under hemodialysis. These patients, as we know, face several struggles, several physical limitations, the disease that cause the loss of renal functioning, and so on and so forth. And we investigate the level of happiness in these patients under hemodialysis. First, we found that they were happier than we had supposed previously. But what was more shocking for us was that no socioeconomic or clinical variables were related to quality of to happiness. Age, gender, education, number of physical comorbidities, level of hemoglobin, anemia, even the quality of the dialysis. None of these were statistically significant related to happiness. But private religiosity and intrinsic religiosity were directly related to happiness. So as we know, even in such a critical condition, and that has a lot of impact on patients, the level of religious involvement was important. It's also interesting to understand that organizational religiosity was not correlated to happiness in the sample, probably because of the physical limitations. They were limited in attending religious services. However, the private religiosity and intrinsic religiosity was correlated with happiness in this population. Another important data regarding substance use, as we said previously, we have many studies about the impact of religious involvement and in substance use. And what about when the protection fails? For example, the patient develops a severe dependence. See, here is a sample of 600 crack cocaine addicts in patients. Okay, we investigated among them the level of religious involvement in adolescence when they were teenagers. What we found was those patients who had higher levels of religious participation between 15 and 16 years old had half of the chance of starting the consumption of crack cocaine before 18 years old, half of the chance of having very high levels of consumption, more than 10 crack rocks per day, and lower levels of higher craving. So as we can see here, despite the protection failed in some sense, it buffered the impact, in the sense they had less severe crack cocaine dependence. Okay, let's move on to other aspects of the position statement. The idea that spirituality is related to the transcendent, the sacred, the ultimate reality, providing meaning and purpose. And religion as the institutional aspect, a system of beliefs and practices that's shared by a community. But the crucial idea of spirituality is the transcendent aspect of reality that is sacred, of ultimate significance. And because of that, here we have now the 7 directions, the 7 items of the guidelines that direct the practice of psychiatrists around the globe. First, the idea that understanding the spirituality should be central to clinical and academic psychiatry. The first point is that we should take a spiritual history. We should consider patients' religious beliefs and practices and their spirituality should be routinely considered. It sometimes is an essential component of psychiatric history. So this is one of the most accepted implications of all this research in spirituality, that we should include taking a spiritual history, even if it's a brief spiritual history in patients to understand better their life. But there are some stumbling blocks that make it harder. This is a research from some colleagues here in Brazil with almost 400 psychiatrists. And they found, it's very interesting, that although most of them think that it's important to integrate spirituality in clinical practice, 77% agree that's important. Most of them refer some barrier regarding this. One third of these psychiatrists think they have fear of exceeding the role of doctor, crossing ethical boundaries. 22% lack of training, 16% lack of time. But what we actually see here, that a good training would help them to overcome these three major barriers. Since with a good training, they will be able to not trespass ethical boundaries. They will not take so much time on this, and they will have the training. Okay, and it's also another interesting finding that they got here, that the fear of exceeding the role of doctor was higher among the religious psychiatrists. Because they are religious, they are afraid of, perhaps I may impose my beliefs, so they are afraid of that. So of course they need also a training to overcome this. And to overcome this problem, we have developed a program, a curriculum in spirituality to psychiatry residents. Okay, this is a partnership that we are developing with John Petit from Harvard University. I'm mentoring a psychiatrist who is doing a PhD, Fabrício Oliveira, and we developed in partnership with Alan Funk, who is also here with us here in this meeting. We first performed a systematic review of the literature. What are the evidence about the implementation of curriculum on spirituality in psychiatry residents around the globe? Based on that, we developed a basic curriculum, a 6 lessons curriculum. The idea would be a short curriculum, only 6 lessons, each lesson about 2 hours, each class, to train psychiatrists. Currently, we are now implementing this curriculum in 15 different psychiatry residence programs in Brazil. So we hope next year we'll have results. We'll have results about this and see how it changes attitudes, knowledge of psychiatrists, psychiatry residents. And we hope later to adapt it to a more international use also, to overcome this barrier that we have, the lack of training among psychiatrists. And also, another very important aspect in terms of taking spiritual history is using good instruments to take spiritual history. And this is a systematic review of the instruments taking spiritual history by a colleague, Giancarlo Lucchetti, and showed, for example, the FICA, only 4 questions to address 4 dimensions of spirituality, and it takes only 4 to 5 minutes. It's a good strategy to use and to apply in clinical practice. There are other more developed interviews, for example, the Royal College of Psychiatrists, that allows us to go deeper on these spiritual aspects. But if you have a shortage of time, FICA definitely is a good option. The other point, the second point of the position statement, is that the understanding of religion and spirituality and their relationship to their diagnosis, etiology, and treatment of psychiatric disorder, especially the aspect of differential diagnosis of spiritual experiences, and how could we integrate also spirituality in the treatment. And there is the need of more research on clinical applications. This is one of the major limitations that we have nowadays. We already know that spirituality matters for mental health, but the point is, how can we translate this to clinical practice? This is one of the major challenges that we have nowadays. This is exactly the reason of this book that we recently published, emphasizing the clinical applications. Okay, and also there is a need of studies covering a wide diversity of cultural and geographical backgrounds. Most of studies that we have nowadays are from North America and Europe, but is increasing the research base in different cultures beyond Christianity, for example, in the Eastern world. And so. But another very, very important aspect, it must never be an imposing of views, religious views or anti-religious views. It's important to understand that the proselytism can happen in both directions. Sometimes the professional could try to proselytize for their own religious perspective, but also it's not uncommon. Patients complain of being proselytized by clinicians to anti-religious perspectives, in neglecting or even treating respectfully the spirituality of patients. So the approach must be person-centered. We need to be open and humble to understand what matters for the patients. This is what matters to us. So we need to understand what matters to patients and how can we help patients to use their religious and spiritual resource to deal with, to cope with the challenges that they are facing. And exactly in trying to translate some clinical applications, this is a review paper that we published with Giancarlo Lucchetti and Harold Koenig. The idea that we should not never prescribe any posing. We need to take into consideration all aspects of patients, physical, mental, spiritual. We as clinicians, we also need to explore our own worldviews, our own religion and spirituality, our history. We need to be very careful when a patient starts talking about some spiritual aspect and it impacts too much on me, in positive or a negative way. If it is touching me too much, be careful with the counter-transference and be careful to really work in the better interest of the patient. And I think perhaps this last point was one of the most important, an open-minded approach with genuine interest and respect by patients' beliefs, values, and experience. This is one of the most important aspects. This more general aspect, as we talked previously about the clinical implication, taking spiritual history, having a respectful approach, person-centered approach. And we have more and more now evidence also about spiritually integrated psychotherapy. This is a paper that we have just published with another colleague here from Brazil about the religion-adapted cognitive behavior therapy. The major point is we have nowadays some systematic reviews of controlled clinical trials about religious modified CBT. But it's not enough just to read and know that religious CBT impacts positively, has a good positive impact on patients. We need to know how to translate this to my own clinical practice. In this paper, what we did, we analyzed the protocols of the interventions that showed efficacy in clinical trials. So it would be much easier for clinicians to translate it to clinical practice. For example, the main techniques tested in this clinical trial and proved being effective were first, for example, the psychoeducation, discussing with patients about the religious theories for the causation of symptoms, and also to motivate patients, sometimes based on their religious backgrounds, to adhere to treatment, to be motivated to treatment. And also, we can explain the relationship between thoughts, behavior, and emotion using their own religious content. And how, for example, many religions emphasize the impact of worldview, how you see things, how it impacts your emotions, and things like that. Also, we can use the religious activities as motivational strategies. We could encourage patients, for example, to behavioral activation in attending religious services, in working in a voluntary organization. Also, we can during the spiritual history, I can ask patients, tell me about your religious beliefs, your religious practices, how they impact your life. Tell me about religious practices and beliefs that were useful for you in the past. Sometimes they had some religious spiritual coping skills that were useful in the past, but they are not using it anymore. So we can help them to think about this and perhaps to use again. Sometimes it's very interesting also, we have found this in some studies, but also in clinical practice, that just taking a spiritual history may be some sort of intervention. Because just taking a spiritual history helps patient to remember about his or her own spirituality and how it could be helpful. And it was helpful, and it may be helpful nowadays again. So it's quite often, after just taking spiritual history, the patient start to be more involved in his or her religious coping strategies, for example. Also, another very important aspect is also regarding life values. For example, forgiving in divorce. For example, we know that forgiving is sometimes something very important for their mental health. So this is one possibility. And also, cognitive restructuring. Patient can reframe their views of themselves and how they understand the struggles that they are facing in different perspectives because of their religious background. For example, a patient who is feeling deserted by God, abandoned by God because he did something that he thinks is very bad. If, for example, the patient is Christian, we could discuss with him how Jesus dealt with people who made mistakes, with the sinners. So we could discuss with them, with the prodigal son, for example. It can have a much higher impact on our Christian patients than just discussing this topic only in a non-religious secular way. So again, the important point is we should never impose anything, but we should only use the own patient's background and resources. Another aspect important in clinical applications is regarding differential diagnosis. When patients start having visions, hearing spirits, the Holy Spirit, hearing God, having visions, trance, whatever, how can we make this distinction? So here, for example, it's a study. We did a 1-year follow-up of people who seek religious groups because of psychotic experiences, but that were not exactly psychotic symptoms, but this kind of anomalous experience that were understood in a spiritual perspective. For example, out-of-body experience, precognition, having visions, hearing voices, and things like that. What was most interesting, they were received in this religious group, and after 1 year of follow-up, we investigated the predictors of the better quality of life. It's interesting. They just have this kind of unusual experience, this psychotic experience, were not predictors of quality of life. It doesn't matter if they had higher or lower levels of these anomalous psychotic experiences. But if they had cognitive disorganization, was a predictor of a worse outcome. And if they had higher levels of self-directedness, it was a predictor of higher levels of quality of life. So it means this is one of many examples nowadays that we know that to make this distinction, the positive symptoms like hallucinations, for example, are not a good distinguisher. Are not good to make the distinction between healthy spiritual experiences from psychotic disorders. We need to take consideration other aspects. For example, cognitive disorganization, negative symptoms, the impact in functionality and self-care, and so on and so forth. Okay. We also have performed some studies, neuroimaging studies. This is a SPECT study. This is a fMRI study about trans mediums having their experience of having visions, out-of-body experiences. And we found, for example, in these visions, they actually had a higher level of activation in occipital lobe related to the vision cortex, visual cortex. But, for example, they had no changes in the full mode network in resting state. So the basic function of their brain is working properly, and they had a higher activation during the trance in areas related, for example, with the visual perception. That this higher activation of occipital lobe was higher than when they were just reliving the experience in imagination. So this is one other sort of example. We also have published some studies about in-depth case reports of people who had this sort of spiritual experiences. For example, we published a few years ago about an African Brazilian religion, a priest of an African Brazilian religion, Candomblé. And here, another published this year, a famous Brazilian spiritist medium who is now 93 years old, who has had this sort of anomalous experience for more than 90 years. So we perform an in-depth analysis. It's very interesting in both cases is exactly what I said previously. The frequency of positive symptoms like hallucination is not a good predictor, but the good predictor for mental disorder are negative symptoms, cognitive disorganization, and other functional impairment that both did not have. And also it's very interesting because in the beginning, both of them were very afraid of their experiences. They were not well accepted by their religious groups and their families. So it's important to take in consideration that the experience, even the healthy experience, can cause distress, suffering, and impairment, not because of the experience itself, but because how the experience is framed, how it's interpreted. For example, they interpreted in the beginning that their experience were madness or demonic influence. Of course, neither is good. So they were afraid and anxious of becoming mad or under demonic influence. When they were able to reframe this experience in a more supportive spiritual environment, they were able to integrate this experience in a positive way and lived a very fruitful life. Okay? And because based on this, we have discussed in some criteria for differential diagnosis between these experiences. We published a paper some years ago where we summarized this criteria. But basically, I had discussed this criteria. And then the final 3 points of the position statement: psychiatrists, whatever their personal beliefs. This is very important. Taking in consideration spirituality is not related with, or should not be related with, the personal beliefs of psychiatrists. As we said previously, the approach must be person-centered. And not only this, but we need to be willing to work with leaders and members of faith communities. We can have partnership with faith communities. For example, in suicide prevention. For example, in substance use disorders prevention, for example. The American Psychiatric Association has an initiative on faith communities and psychiatry. And also psychiatrists should respect the spirituality of many of the staff and volunteers, and also the impact of spirituality in forming a vocation to work in the field of mental health care. There are some studies showing that spiritual reasons are very common among mental health professionals, for example. The reasons for why they choose this area. And not only this, there are some studies showing that seeing our profession, mental health profession, even psychiatrists, seeing this as a spiritual vocation is related to less burnout and higher levels of meaning in the profession. But of course, we need to understand both the potential both benefit and harm of religious, spiritual, and secular worldviews, and also be able to share this information in an impartial way to wider community. So these are some other aspects on this. So regarding this partnership with faith communities, as I said previously, the American Psychiatric Association has an initiative led initially by Paul Summergrant when he was president of the APA. And we published recently a paper exactly about this, a interdisciplinary collaborative partnership for global well-being. I think that's the point. If our goal is to improve the well-being of humanity, it will be very important to work in collaboration with different parts of the society, instead of seeing each other as competing for the same public. It would be much better if we could work together in improving and helping our patients. So finally, the reasons for integrating religion, spirituality, and mental health. Most of the world's population has some sort of religion and spirituality. It's a very frequent coping strategy. It impacts health. Addressing religious spirituality impacts the prognosis, the follow-up of these patients. Patients want that clinicians address, usually patients want that clinicians address their religion and spirituality. It's a component of integral patient's assessment, and it's recommended by medical and health organizations. So why do religion and spirituality mean? Why should we take this in consideration? In respect to the evidence available and to religious beliefs, behaviors, and values of most of the world's population, is not only appropriate, I think this is the most important point, it's not only appropriate to take this in consideration, but it is a scientific and ethical responsibility to integrate it in clinical care and public health. Because if you know that impacts a great deal on mental health, and if we know that most of the world population have some sort of religious spirituality, it's our ethical and scientific responsibility to take this in consideration in order to help to improve our patients and our population. So for those also who, and as an initiative to spread the word about the importance of science and spirituality, this is the YouTube channel that I told previously, TV Nupes. It is bilingual. It has many videos in Portuguese and in English with many experts around the globe in different aspects of spirituality and mental health, more than 300 videos. And also here we have, you can see here, this last one is the web page of the WPA section in religion and spirituality, religionpsychiatry.org. It has not only the position statement in 7 different languages, but has also many more information, many other news and resources for those interested in. And also here we have my contacts and also the website of our research group. Thank you very much.
Thank you. Thank you so much, Alexander. What a fabulous presentation. And you have done so much work. It's just amazing, all of the publications, and all of the work that you've been involved in. So now we have 15, 16 minutes for people to simply, ask you questions about this whole area. So just go ahead and unmute yourself and ask a question to Alexander. Richard?
I can ask a question. Yeah.
Good.
It was in relationship to number 5, where psychiatrists are to engage with pastors and so on and so on and so forth. And I was wondering really how that worked at an academic level in terms of psychiatry engaging with, say, religious studies, which is a whole academic discipline which addresses some of the common ground that you're involved in. But, you know, I've read a lot of papers, psychiatric papers, and I'm always surprised how little reference there is in the bibliographies to papers that come from different disciplines outside of psychiatry. And there seems to me, you know, this isn't, you know, I'm not setting up this critique, it's more an encouragement that psychiatry could be less insular by engaging more fully with religious studies disciplines, you know, people who do religion as their profession all of the time, studying it, not practicing it.
Yeah, thank you very much for your comment and question. Yes, definitely. It's very important for psychiatrists to be aware of different fields who have done study on spirituality and even spirituality and health. I think we need to do better in making these bridges with different academic fields, and also not only with academic fields. And as I said previously, and also is the fifth point of the position statement, in partnership with faith communities around the globe. But some initiatives have been done, as we said, the APA. The WPA also is developing initiatives in this sense. We are trying to do this here in Brazil also. So in India, I know also that there have been some partnership between psychiatric associations and spiritual groups, but we know it's challenging because what are the boundaries? Sometimes religious communities are suspicious of psychiatrists, and psychiatrists are suspicious of religious communities. So we need to overcome these barriers. But I'm very optimistic in what's happening until now.
Okay.
Don't be shy now. Wayne.
Okay. I was very pleased that you had 4 dimensions, my way of putting it: the physical, mental, the spiritual, and the relational. That a whole person is sitting there. What I was hearing was that in the past, the foot doctor deals with the feet, the heart doctor deals with the heart, psychiatrist deals with this material inside here. And now you're advocating that, no, see the whole person sitting there, hear the whole person, get to know the whole person. And which makes a world of difference. And I've had some experience sort of co-working with psychiatrists where they were simply had their little block and they were imposing their religion on the other person even. And so I had to flesh out the part they weren't dealing with. So I think it's exciting that you're seeing the psychiatrist sitting with the whole person.
Wayne, thank you very much. Yes, I think that I think this is a plague, but for human beings as a whole, we tend to stick to only one perspective and reject different perspectives. This is very, very frequent. This. And my perception, for example, in the religious communities, it's quite frequent, as we know, some religious communities that think just the religious aspect will solve problems. It's quite frequent. For example, for me, I myself, I receive patients who knows that I deal with spirituality and religion, and they think that I will remove the antipsychotic that they use. I will remove the mood stabilizers because I will think that everything is just a religious aspect. On the other side, also, sometimes when I talk to medical community, quite often they think that I'm neglecting the biological, the psychological, the social aspects. Of course not. I think to emphasize It's something quite obvious, but must be said because people tend to stick in just one perspective. We know people who defend psychotherapy and are against medication, people for medication are against the social aspects, and we don't need to choose this. It's not either or, but yeah, I think, yeah, I agree. Thank you very much.
Alexander, this is Francis Liu. Thank you.
Great to see you.
Thank you very much for your wonderful presentation. I put in the chat a link for a resource document that appeared in April of this year as an APA resource document. This actually originated from the ethics committee of APA with input from the executive committee of the caucus on religion, spirituality, and psychiatry at APA. So when you mentioned in your last slide the ethical imperative to pay attention to this, I think that it aligns very well with this resource document that brings up this perspective as well. So I wanted to share that resource with everybody on this call.
Yeah, thank you very much. Francis Liu has done amazing work in promoting these different aspects of spirituality and providing resources to us. Thank you very much, Francis. A great honor having you here.
It is indeed. Somebody in the chat asked, was actually Dr. Iona asked everyone, can you give us, Alexander, can you give us examples of positive and negative religious cognitions?
Okay. For example, let's start with the negative aspects. The patient may, for example, have a more passive coping because of religious perspective. For example, they are facing a problem, depression, for example, or marital struggles, and they believe that they are being punished by God, or that because of karma of previous reincarnation, or because of demonic influence on them, and they just wait and ask for God to solve the problem. This is one example of this passive deferral, negative cognition. Another negative aspect, for example, is when they feel punished, but not only punished, but abandoned by God. For example. They think that they are sinners, they committed something very bad that is unforgivable, and then they think that they are damned. I think this is another frequent experience that many patients have. Regarding the positive cognitions, for example, the idea that life has a purpose, that God is taking care of all of us, and if something is happening, is for our good and for us to learn something of it. And more, if God is love and God is good, He will never allow me to face something that I cannot cope with. So this idea that the challenges are, or my coping skills are the level of the challenges that I face. This is, for example, a very good example of positive religious cognition. These are some examples.
Good.
Sorry, can I ask a question? Hello there, Alexander. Thank you very much for this fascinating presentation. I'm a psychiatric doctor also from the UK. I do actually come across a lot of patients, of my patients, who I think that they would benefit from some sort of spiritual interventions. But what I always find that I don't think that we have the right qualified people to deliver the service at this moment of time. So who is it you think that is kind of best positioned to deliver spiritual care? Is it the chaplains that we already have? Or is it something like to do more with psychotherapy, like to train psychotherapists in spiritually oriented therapies, or who is really the right person, or is it the psychiatrist actually who could do that? Thank you.
Okay, thank you, Tarek. It's a very good question. We don't have a definitive answer, but I think all of these actors can collaborate. For example, the simpler strategy that I think all psychiatrists on mental health clinicians can do is taking a spiritual history, and in taking the spiritual history, identifying the positive religious skills that patient have and stimulate the patient to use it. The same sense, for example, when I do a good psychiatric interview, I investigate the social relationships of the patient, the hobbies, the sports that the patient practices, and I stimulate these positive aspects of their lives. So we can do the same regarding spirituality. So this is the most simple strategy. This is one point. I think everyone with a little training can do this. Okay, and by the way, we have just with Francis Lu proposed a course for the APA meeting next year exactly about this. We hope they will approve it and they will work on this there. So this is one point. The second point regarding psychotherapy. Yes, I think we can learn how to use spiritually integrated psychotherapy. This is one of the reasons that we published that paper, showing if someone is a CBT therapist, it's quite easy to adapt some aspects of the CBT to include patient spirituality. So in that paper, for example, we tried exactly to give some examples. I know that the Harvard Carnegie has in his website several protocols on how to integrate spirituality in different religious traditions in psychotherapy. So I think we can do this. And of course, also, we can refer patients to their own religious communities. They also can benefit from talking to having some support for their own religious communities, and also with chaplains. I think we can work together. And of course, each professional, each clinician will feel how far the clinician can go, how far he's prepared to go in this topic.
Excellent, excellent. Camelia, go ahead.
Yes, yeah. So Dr. Moreira, thank you so much for your presentation. I'm also a psychiatrist working in Canada, and I have a slightly similar but different question. So in contrast to the WPA position statement on religion, I'm not sure if you are familiar. So the CPA, Canadian Psychiatric Association position statement, published a statement in 2014, which is slightly different. Actually, it's quite different. So while emphasizing rather the detrimental effects of religion and spirituality, they concluded, I'm going to actually read that sentence to you. So for these reasons, we believe that psychiatric care, while sensitive to the spiritual, religious, and cultural needs of the patient, needs to be provided in a secular fashion. So the first author of this position statement is Dr. Gary Chimovitz, who's a forensic psychiatrist, kind of focusing probably more on the legal aspects. But my question for you is, for psychiatrists practicing in Canada who feel more aligned with the WPA position statement, who really feel that the importance of religion and spirituality in patients' care is major, kind of trying to practice under the influence of these two very opposed views, what would you advise? What's the guidance that you would give in this context?
Okay. First of all, congratulations. Thank you very much for your question. First of all, I think that quite often clinicians and institutions are suspicious about religious interference, and many of us also have examples of bad influence of religious ideas or impositions on psychiatric patients. Of course, we need to be aware of this, but we cannot just look at this negative aspect. We need to understand that by large, most of the parties a positive interaction. I think we can work on this. So the idea of the WPA position study was exactly to help clinicians around the globe to be more motivated and supported in taking in consideration spirituality in a more respectful and also scientifically based way. But specifically regarding to Canada, perhaps Alan Fung, who is here with us, who is also a psychiatrist from Canada, who is also a member from WPA and also the APA caucus, perhaps he could give you a better advice regarding Canada.
Great. I'm mindful of the time here, but thank you, Camille, for the comment. Certainly, I've noticed, the CPA statement, and I've brought it up actually at APA and WPA conferences about that issue. We are really needing to do more work, with the CPA about the importance of religion and spirituality. Probably from the cultural lens at this point, we are hoping that the cultural psychiatry people in the CPA would have some buy-in, of the religious spiritual aspect. Definitely, the APA is also trying to work more on that aspect. But, I welcome the opportunity to collaborate, and we can further the conversation at the CPA.
Great, Alan.
Thank you very much.
If I could just
Go ahead, Simon.
yeah, sorry, my name's Simon Lasser, and I'm one of those guys with a PhD in religious studies who also works as a frontline spiritual care practitioner chaplain from Canada. I'm actually a colleague of Camellia, and I think that one of the things that needs to be recognized in this conversation is the presuppositions that are inherent within a secular worldview that are somewhat at odds with many of the presuppositions that are inherent within religious worldviews. And so I think by recognizing those different frameworks that we bring to reality, what that reveals is the need for a very strong effort around translation between religious worldviews and psychiatric worldviews that are very much embedded within a very strong secular approach, scientific approach to many of the phenomena that religious people would be experiencing that might require psychiatric care. And so I do wonder whether, just to echo the comments that were made at the beginning of the session, I do wonder whether there needs to be a slightly more relationally oriented approach to examining some of these challenges that we're encountering in terms of the translation. How do we approach psychiatric issues through the lens of relationship and through the frames that people bring to their very experiences of reality that may condition how receptive or non-receptive they are to psychiatric care? Is there a way of changing the discourse, shifting it to a more qualitative orientation as opposed to a very strong sort of quantitative orientation that in some ways is the foundation of psychiatric science, so to speak?
Thank you, Simon, for your comment. Yeah, definitely. I think that one of the major needs that we have in spirituality and psychiatry is have better qualitative studies. I think the first step, and Dr. Koenig was a major lead on this, was to show that we are doing serious science. We are providing hard evidence that it matters. I think that's the point, to overcome a huge resistance in scientific community. After this, I think now we are in this moment now, definitely we need to understand better what is the experience of each person dealing with spirituality in their struggles. So definitely good qualitative studies will be very, very informative. And of course, if the discourse that I have here, I'm having this discourse here because I'm talking to academic audience. But of course, if I would talk to a religious audience, if I'm talking to, of course, we need to adapt our discourse to be more in line and tuned with different audiences. But definitely in this sense, a better understanding of the qualitative aspect of this experience and the recognizing value, even the challenges, the problems that exist will be essential.